What's up everyone, it's Miles here from bootcamp.com, and today in pulmonology, we're going to begin our pathology section by starting with a chapter on lung pathology fundamentals. So today we're going to be talking about the lung physical exam, which is an important concept in introductory lung pathology because a lot of these lung pathologies will first be detected by different techniques during the lung physical exam. So first we're going to start off by talking about lung auscultation and breath sounds. The first two sounds that we're going to talk about are rails and crackles, as well as rhonchi. So rails and crackles are little popping sounds that you can hear after the opening of previously closed small airways and alveoli. So in certain conditions like pulmonary edema, pneumonia, and pulmonary fibrosis, we're going to get the closure of alveoli and small airways, and as they open back up, we're going to hear a little popping sound that we call crackles or rails. And in contrast, rhonchi is the sound of difficult airflow through larger airways, such as in conditions like COPD. And rhonchi sounds like bronchi, so that helps me to remember that rhonchi are heard in the large airways like the bronchi. Okay, and the next two sounds that we're going to talk about are vesicular breath sounds and bronchial breath sounds. So the vesicular breath sounds are normal breath sounds that we hear over the lung parenchyma, whereas the bronchial breath sounds are the normal sounds heard over the large airways. However, if we hear the bronchial breath sounds over the lung parenchyma, then this is pathological. So bronchial breath sounds are pathological if we hear them over the lung parenchyma. And a classic condition where we hear bronchial breath sounds over the lung parenchyma is in pneumonia. Okay, and the last two sounds that we're going to talk about are wheezes and stridor. So wheezes are predominantly sounds of expiration, and we hear them as air is expired through narrowed airways. So in conditions like asthma, COPD, and foreign object obstruction, we can hear the sound of wheezing as air is expired through those narrowed airways. And in contrast, stridor is predominantly a sound of inspiration. And the sound is made as air is inspired through usually an obstructed trachea or larynx, and so we're going to hear it as a very harsh and loud sound over the neck as air is inspired through the upper airways. And we classically hear stridor with infection of the upper airways, such as in laryngotracheobronchitis, also called croup, caused by the parainfluenza virus, and also in epiglottitis, classically caused by Haemophilus influenzae. Okay, so the next lung physical exam technique that we're going to be talking about is percussion. So in percussion, what we're doing is we're tapping on the chest over the lungs and we're listening for what sound is produced. And because the lungs are filled with air, this tapping should produce a resonant sound, and this is the normal sound. In this way, we can kind of think of the lungs as a drum. When we tap on the lungs, it's going to produce a sound just like when you tap on the drums. And in certain pathologies, when we tap on the lungs, the sound might be more dull than normal, or it could be louder than normal or more hyperresonant than normal. So if the tapping happened to be more dull than normal, this can indicate conditions like a pleural effusion or pneumonia. In pleural effusion, we have fluid accumulation in the pleural space, and in pneumonia, we have the accumulation of exudate within the lungs. In both of these cases, the fluid or the exudate is going to dull the sound of the tapping, so we're going to get dullness to percussion, kind of like if you filled up a drum with water or mud, when you tap on it, it's not going to produce a very resonant sound. In contrast, if the tapping yields a hyper-resonant sound, this could indicate things like pneumothorax or emphysema. In these conditions, we have hyperinflation of the lungs. There's more air in the lungs than normal. So in this way, the lungs are essentially being turned into a larger drum than normal, and so when you tap on it, it's going to produce a more resonant sound than normal. Okay, the next physical exam finding that we're going to talk about is tracheal deviation. So depending on what lung pathology is present, the trachea can be deviated towards the affected lung or away from the affected lung. So if the disease process in the affected lung is generating negative pressure, then the trachea is going to be deviated towards this negative pressure. It's going to be deviated towards the affected side. Whereas if the disease process within the affected lung is generating a positive pressure, then the trachea is going to be deviated away from the positive pressure or away from the affected side. And one condition that classically presents with negative pressure on the affected side is a resorption atelectasis. So in resorption atelectasis, what's occurring is we have our alveoli, and classically there's some sort of obstruction in the airway or a mucus plug. So let's just draw in a mucus plug here. So now the air distal to this mucus plug is trapped within the alveoli, and what's going to happen to this air is it's going to get reabsorbed back into the tissues and back into the blood. And as the air is getting resorbed, the alveoli is going to collapse, hence the atelectasis. However, as the air is getting resorbed, we're also going to be generating a negative pressure within this alveoli, and that's going to cause the trachea to deviate towards the side of the resorption atelectasis. And in contrast, a condition that classically creates positive pressure is a tension pneumothorax. And so what's occurring in a tension pneumothorax is the lungs are collapsing as air is accumulating in the pleural space. And in this type of pneumothorax, as air accumulates in the pleural space, that air is going to generate a positive pressure, and that's going to push or deviate the trachea away from the affected side. Okay, the next lung physical exam finding that we're going to be talking about is digital clubbing. So digital clubbing is the abnormal growth or clubbing of your fingers like seen in this picture here. And in lung pathology, what's really driving this disease process of digital clubbing is something called hypertrophic osteoarthropathy. So what occurs under normal conditions is we have megakaryocytes present in the bone marrow, and they are going to be released into the blood. They then migrate to the pulmonary circulation, where they get lodged in the pulmonary capillaries, and from there they release platelets into the circulation. And what occurs in many lung pathologies, such as lung cancer, cystic fibrosis, or pneumonia, is that when there's a disruption in normal lung tissue, then blood vessels will proliferate and shunt past the diseased portion of the lungs. So when these shunts form, the megakaryocytes can actually use these shunts, and so instead of getting lodged in the pulmonary circulation, the megakaryocytes will travel through these newly formed blood vessels, and they too will shunt past the lungs. When the megakaryocytes bypass the lungs, they are then going to continue to travel, and the next place that they're going to get lodged in is the body capillaries, usually the capillaries in the distal extremities. And once they're lodged in the distal extremities, the megakaryocytes will begin to release factors such as VEGF and platelet-derived growth factor. And these molecules promote abnormal bone growth, which leads to the digital clubbing. And so in summary, the megakaryocytes are going to bypass the lungs and deposit in distal tissues. In the distal tissues, that's where they're going to release VEGF and platelet-derived growth factor, which are then going to promote abnormal bone growth. Okay, and the last lung physical exam finding that we're going to be talking about is tactile fremitus. So what we're looking for in tactile fremitus is the vibrations that the voice makes as it travels through the lung tissue. And what you have to know for tactile fremitus is the more dense the lungs are, so the higher the density, the more that vibrations will be able to be felt. And the classic condition where the lungs have a higher density is in pneumonia due to a process called consolidation, which is essentially just the alveoli getting filled with bacterial exudate. And so it's high yield to know that in pneumonia, there's consolidation, which is going to increase the density of the lungs, and that's going to lead to a higher tactile fremitus on lung physical exam. And so the way that we test for tactile fremitus is we place our hands on the patient's back and we ask the patient to say 99, and we feel the vibration of their voice on our hands. And in pneumonia, these vibrations are going to be stronger because vibrations travel better through a consolidated lung. And furthermore, in conditions like pneumothorax or a pleural effusion, we're going to have fluid and air in the pleural space, and that's going to distort the vibrations of the voice, and that's going to lead to a decreased tactile fremitus. And I just wanted to mention two other techniques that follow very similar principles to tactile fremitus. So the first technique is called whispered pectoriloquy. We usually ask the patient to whisper something like 1, 2, 3, and then we listen at their back. If a consolidation process is present, like in pneumonia, then the vibrations of their voice will be able to travel very well, and so their whisper will be able to be heard very loudly at their back. Not only does the consolidation process allow the vibrations of your voice to travel very well, but it's also going to change the quality of your voice. In egophony, we ask the patient to say the E sound, and we listen at their back, and if a consolidation process is present, it's going to come out like an A sound because the consolidation is changing the quality of their voice. Okay, so now we're going to summarize some of the lung physical exam findings in different common pathologies. So the first pathology is going to be pneumonia, and recall that we said in pneumonia there's going to be rales and bronchial breath sounds. As well, because of that bacterial exudate in the alveoli, we're going to have dullness to percussion, and that consolidation process is going to result in an increased tactile fremitus. The second pathology is pulmonary edema, and recall in pulmonary edema, we're going to hear those rales and crackles, and because of that fluid accumulation, there's going to be a dullness to percussion. Next, we have COPD, which recall can have rhonchi and wheezes. We have all those mucus plugs in the airways and the airway collapse. And behind those plugs and airway collapse, we can have air trapping and hyperinflation of the lungs, which can lead to a hyperresonant percussion. And similarly, in asthma, when we get bronchoconstriction, we're going to hear wheezes. And behind that bronchoconstriction, again, we can get air trapping and hyperinflation of the lungs, which is going to result in a hyperresonant percussion. And both of these findings are really during an asthmatic attack. So for pneumothorax, we have spontaneous pneumothorax and we have tension pneumothorax, and we're going to be talking about both of these more in the video on pneumothorax. However, for now, remember that there's two things happening in a pneumothorax. The first thing is lung collapse, and because the lungs are collapsed, we're not going to have air going in and out of the collapsed lung. And so as a result, we're going to see decreased or absent breath sounds in the collapsed lung. The second thing that's occurring is that air is accumulating in the pleural space. And so because we have more air than normal, there's going to be a hyper-resonant percussion. One of the major differences between spontaneous and tension pneumothorax is the air that accumulates in the pleural space in a tension pneumothorax is generating positive pressure, and as a result, we're going to see tracheal deviation away from the affected side in a tension pneumothorax. Okay, and the next pathology is a pleural effusion. So recall that in a pleural effusion, we're going to have a lot of fluid accumulation in the pleural space. So first off, it's going to be difficult to hear breath sounds through that thick fluid layer, and so there's going to be decreased breath sounds. And second of all, when we percuss or tap on that fluid layer, it's going to produce a very dull sound, and so there's going to be dullness to percussion in a pleural effusion. And lastly, if the pleural effusion is very large, we can actually push the trachea away from the pleural effusion, and so we can have tracheal deviation away from the affected side if the pleural effusion is severe. Okay, so the next pathology is atelectasis, which is collapsed alveoli, and so due to that collapse, we're going to have decreased or absent breath sounds. And now, since there's less air in the lungs, we're going to have a dullness to percussion. And furthermore, like we said, in resorption atelectasis, we can generate negative pressure in those alveoli as the air is getting resorbed, and that can cause the trachea to deviate towards the affected side. Okay, and lastly, we talked about epiglottitis and laryngotracheobronchitis, also called croup. Remember that these produced a loud, harsh inspiratory sound called inspiratory stridor that was best heard over the neck. All right, and that's all we got for our video on lung physical exam.